We adapted the framework in two main ways. So number one, we added a special focus on primary care, meaning that whenever we asked our interviewees and relevant stakeholders questions of how health purchasing functioned, we asked them about the specific function as a whole and then the specific function in primary care. So for example, how are contracting arrangements done for the whole health system? And then we dove in deeper and asked how are contracting arrangements done specifically for primary care and for the public and private sector in primary care. Another way that we adapted the framework is that we actually, so we focused specifically on the core purchasing functions that SPARC has identified, which were benefit specification, contracting arrangements, provider payment, and performance monitoring. But we also had a governance section, which was slightly different from the original framework because it was used to encompass anything about the background of the health system, the stakeholders in the healthcare financing space, the regulatory environment. So I know that SPARC divides governance arrangements and external factors in the framework, but we kind of added them together because we wanted to keep that part simple and unified. And we were quite familiar with the framework before starting to apply it. So we found that there was no need to actually change how the core purchasing functions were defined. That really fit well with what we were trying to research and look into. Another minor tweak that we made, though, was that before delving into the different functions of strategic purchasing, we also specifically listed out for each country the percentage of the current health expenditure of each financing scheme that we looked at, and the coverage in terms of the population size that was covered under a particular scheme and what percentage of the total population of a country that corresponded to. And we listed the name of the purchaser for that specific scheme. So these are kind of background information factors that we provided, and then we went on and we broke down the purchasing for each financing scheme according to the SPARC framework. So for each country, we actually looked at whatever the main health financing schemes were, but we didn't look at all the health financing schemes in existence, obviously. So the average for each country was 2 to 5 schemes. And that really depended on the level of, I guess you could say, fragmentation or the different functions of different schemes. So Singapore, for example, has different schemes that are meant to complement each other. So that's why we had to look at all of them together when doing this analysis. And it ended up having 5 schemes in our report. But some countries like Vietnam have mostly one main scheme and then the government funded scheme. So the tax-funded healthcare in general. So for those countries, we looked at maybe 2 schemes, and for others, we looked at a few more. But they were really the whatever major schemes are in existence in a specific country is what we looked into.